Good evening, friends. Welcome back to Pediatric classes. Today, we are going to discuss about yet another important topic, that is peak expiratory flow rate. It will be a very short discussion, but it will be really useful for you, for those practicing pediatricians, and also for those actually studying for pediatrics, and also in those working in periphery, because it is a very useful tool in the obstructive lung diseases. So this is the peak expiratory flow meter, which we use for using the measuring the peak expiratory flow. So I'm taking it out of this case. So this is the peak expiratory flow meter. So this is C+. I'm not endorsing any brand, but this is the one which I generally use. This is written breathometer. Yeah, actually, okay. So it has got different markings and all, which we'll discuss soon in this video. Okay, with this introduction, let me start sharing my screen. And another request is, if those of them who have not subscribed to my channel, please do subscribe to the channel, click the bell icon so that you will get all the videos which I am uploading at correct times. Okay. So what exactly is the peak expiratory flow rate? This is the maximum flow generated during a forceful exhalation, starting from forceful inspiration, and it actually measures how effectively actually you can exhale. So it is expressed as liters per minute. So it reflects primarily the large airway flow. It also depends on the lung recoil, voluntary effect, and also on the muscular strength of the patient. So it actually correlates very well with the forced expiratory volume in 1 second. So about this FEV1, we will discuss in later discuss in detail in another video. Please note and understand that this both will help in the diagnosis and in the treatment and all those things of asthma. But this correlation between PEFR and FEV1, which is better if you ask me, it is actually FEV1. But this correlates almost very well with FEV1. But this correlation decreases in patients with asthma as the airflow diminishes. Okay. And how to measure this? For that only, I showed you this peak expiratory flow meter. It is a portable flow gauge device. It may also be obtained by a transducer that converts the flow to electric output during the spirometry. That is called pneumotachometer. But most commonly, whatever we are using is this PEFR. That is a peak expiratory flow meter. There are two types, small or lower range meter for children and a larger or a standard range for teenagers and adults. So when you use it, we have to use it every morning and evening before taking the medication. And when we can also use it when you have symptoms or attack. To predict an attack also, this will be helpful for you. I will tell you how exactly it will help you and all in this. Subsequently, I will be telling in the following slides. And we can also use this for, like, you had an attack, you have taken the reliever medication, and after that, you can use it to check whether the PEFR of the patient has improved. And if it is improved, that shows the patient is responding to the medications, and you can actually decide upon your treatment. Okay. So what exactly is the procedure? As in any other procedure, we have to wash our hands. Like if suppose, I'm sorry for this spell check. Suppose you're doing it on a patient, or you have to introduce this. I put it because for the postgraduates, they may have these OSCE stations. So first wash hands, introduce yourself, confirm the patient details. Then you have to explain the procedure to the patient, get the informed consent. What exactly is the procedure? You will learn now, okay? And then only you will start the procedure as such on the patient. So once you explain, and then if possible, we can even demonstrate if they are not understanding it. Because if it children may take a bit of a time to, grasp it and then understand and do it fully. Maybe whereas in adolescents and adults, they may do it very well. So whatever it is, don't forget to get consent also. Okay, so what exactly is the technique? So this is the peak expiratory flow meter. You have to check the mouthpiece for any obstructions. Okay, make sure whenever you're using it, don't put your fingers like this, crossing the sliding scale on the top of the device. You have to, make the patient either sit up or stand to get the maximum inhalation and exhale. Don't make them sitting in a hung-sit posture. So they won't be able to do a full inspiration and expiration and all. Okay, and make sure that there is a small red scale thing, can you see a small pointer here? So you have to set it to the 0 value of there. Okay, I'll see if I can show you that in this. See here. Yeah, this one, can you see here? So there is a small pointer out there, but whenever you are using it, make sure that you have actually slid the pointer to the 0 or the lowest value you are seeing onto the PEFR monitor. Okay. Now, I'm sorry, the slide is getting stuck. Okay. So what all did we do? So we have actually checked whether the pointer is onto the 0 or the lowest value. Then ask the patient to take a deep inhalation, purse the mouth around the mouthpiece. As in the diagram given here, you have to purse the mouthpiece in your mouth between the front teeth and seal your lips around the opening. Why we are doing though? Because we want to avoid any air leakage happening when we actually exhale. All the air which we are exhaling should actually go through this PEFR monitor or a meter. So exhale as hard and fast as possible into the meter, and whatever, then you will see that this pointer goes up. And so whatever number you are seeing, you write it down. So please make sure that you have to repeat it. Maybe, once you feel the child is doing well, that or a person is doing well, that don't stop it the first time. Repeat this 2 more times. So total we are doing 3 times, and the best of the value only we do. Please understand here, do not average the value. I repeat here, we are taking 3 times, and of the best value or the highest reading, you will write it down as the PEFR of the morning. Same thing you will be doing in the evening hours, and again 3 times you will do all the same procedure, like take a deep inhalation, then purse your mouth around and just blow as hard and fast as possible. Like it's like this. Then I can actually see this has actually gone up. So this thing should be done very properly. Record the highest of the 3 values. Okay. So you will write 3 values, and of the highest of the value, you will record it. Then, how do you check the PEFR variability? This is very important. This technique is the daily amplitude percent mean method. Though this term sounds very like cumbersome, it's not. It's very difficult. It's easy only. So what we should do is, first we should get the diurnal variability. Diurnal variability means there is a variability of PEFR during the day. So what happens? First we will find out the diurnal variation. That's why the first line I have written amplitude. Amplitude means the variation. So how do we get it? You will get it by the maximum PEFR minus the minimum PEFR divided by the mean of those. So that value will multiply by 100. So that's why I written here the ratio of the daily change in amplitude divided by the mean value expressed as a percentage. That is actually the daily amplitude percent mean method. Why I put it is sometimes, for exams, vivas and all, they may ask you certain questions, and they may ask you how do you calculate PEFR variability. So you can tell the formula, the highest minus the lowest PEFR divided mean into 100. So what Excel is the overall variability. So this actually we are doing for around a span of 1 to 2 weeks. We are not doing in a day. We are doing for daily. We are doing like this. So we will get the overall variability is some value will get that divided by the number of days. That is the average. That is the overall variability we are using it. Okay, I will give you an example for you to better understand it subsequently. So what is the XL? Is a significant variation. Excessive variability in twice daily PEFR over 2 weeks is very predictive of asthma. So average daily diurnal variability according to the GINA 2023, in adults if it is more than 10% and in children if it is more than 30% is taken as significant. But please note here, according to the NICE guidelines, recently updated in 2021 also, they are suggesting the cutoff value as more than 20%. Why I put all these things here? Because sometimes the books you read may show, 20%. Sometimes you may read it as 10 or 13%. Or in your entrance examination, they may ask you this question. Once the questions are asked, according to GINA, like generally we are following GINA guidelines. So I'll go for adults more than 10% and children more than 13% as the best answer for that. Somebody asked me what is the diurnal variation. Okay. So see this, I'm sorry for this clarity, sincerity. So this is how, you can actually plot it like this, or you can actually write it down also. So once you are plotting like this, see this day 1, what are they seeing? Day 1, the blue things are the PM PFR values, and the yellow ones are the AM values, PFR values. You all know, okay, Monday, like in the morning hours, our expiratory flow rates will be relatively lesser compared to the other times of the day. So diurnal variability is, how do we get it? So suppose this is actually almost the highest value is around 280, around 280, I think it will be here. So 280 minus, what is the lowest value? It's 240 divided by the average of the value into 100, which I have written here. Then that means 40 by 260 into 100, which is come as 15.3. Is it significant? So I'm not going to comment upon whether it is significant in a day. So actually, we have to do it over 1 to 2 weeks. So you'll get so many percentage, 15.3, 15.6, so many. And of that, the average of the values of the person means, then we should be taking to say whether the diurnal variation is significant or not. This is a PSCRS consensus. So I have got this very beautiful diagram. So this is what I always ask my patients to do. That is morning, evening. Extra generally they don't do unless we get, in the initial time when we want to get the personal best. I'll discuss about personal best subsequently. Okay. So first, at least these 2 columns should be there, morning and evening. You can actually put one extra in between when you are checking, if at all they are checking, just to know that thing. So what actually has happened? Day 1, 240, evening 330, they are taken as 330, okay? 330, like that, they have written all the values for the morning, evening. Then, what I have, then here you see the daily PF variability, how did they calculate? It is the highest minus the lowest divided by the average of the values into 100. So here they have taken it as 300 minus 240 divided by average of 200 plus 240 plus 300 into 100, which is come as 22%. Then the day 2 comes, again the mother or the father is helping the child, or even adolescent, they are doing by themselves and getting the values of morning, evening, getting the daily PFR variability, they are charting. So what exactly is happening? At the end of 1 to 2 weeks, you get so many values. An average of these values, please note here, average of the daily PFR values, that is 22%, 23%, 18%, 16, 18, 18, 15. So how do you get the average? Add all these things divided by the number of days, that is number 7. You get the PFR variability as 18%. Is it significant? Yes, it is significant by the GINA guidelines, which says more than 10% in adults and more than 30% in children is taken to be significant. So another way of monitoring it, when you actually put the morning and evening value like this. These red dots are the extra ones, okay? So this is also very easy to understand if you are, but for a patient, it's always easy to just write down the values. Depends on the convenience. So there's another concept called PEFR, bronchodilator reversibility. That means, how does the patient respond to a 200 to 400 microgram? Why have done 200 to 400? In children, we use 200 micrograms, and adults, we use 400 microgram for salbutamol after, whether the patient responds after 15 minutes, we again repeat a PEFR. So if the PEFR reversibility is of 20%, we are getting in relation to acute asthma attack, it is taken as significant. So how do you calculate it? Here it is calculated post bronchodilator best of the 3 minus the pre-bronchodilator best of the 3 value divided by pre-bronchodilator best of the 3 value. Best of 3 means I told you initially we will take 3 values, and after that we will take the best value one. Okay. So of that into 100. Again, I'll give you an example. So pre-bronchodilator, I've taken 3 where it is 210, 210, 220. I have given a salbutamol of 200 for a child microgram. After 15 minutes, I am actually checking the post bronchodilator PEFR. Then again, I am getting 270, 280, 290. So what I have done, the best of the pre-bronchodilator, that is 220 is they have taken, and the best of the bronchodilator, 290 also they are taken. So 290 minus 280 divided by the 220, that is the pre-bronchodilator best value into 100, which is come as 32%. So the variation after a bronchodilator is 32%, which is more than the 20%. So this is significant. There is something, one graph like this, actually PEFR normal values. Actually, this depends on the, patient's age, height, gender, etc. So like for an example, like if I say a woman, suppose the patient person is around 167 centimeter. So, and the patient's age is around 40 years. So this is the graph for approximately the normal values for that woman. And this is for men of that particular age. You can just get the chart. But generally in PEFR, no, we don't use the normal values. What we use is the personal best. So because it varies between person to person, race and all, no. So try to find out the personal best also. So how do you get the personal best? Personal best is like, we have to do one extra floor test once a day. For about 2 to 3 weeks we will do. Generally that we do around noon to 2 p.m. time. The best time is at noon to 2 p.m. So, and again 3 times we will do, and the highest of the value we will take. And that over a period, like you will take, suppose you do for a 2-week period, and the highest reading over this period will be your personal best. Okay. So the concept of personal best is the very important here, because you are going to compare all your PEFR values which you get subsequently with this personal best, taking it as the benchmark. Then it is better than predicted value and all. So always remember this in PEFR, try to get the personal best for each and every patient. So now what is this exactly the uses of this peak expiratory flow rate? We have been discussing it again and again. So it helps in the diagnosis of asthma by determining the diurnal variability. I repeat again, it is more than 10% in adults and more than 13% in children according to GINA 2023. And according to the NICE guidelines, it is more than 20%. And it also helps in the home monitoring of asthma, both short-term and the long-term monitoring. So it also can predict attack. So suppose you do and you get a low PEFR, which is very low compared, which is less than your personal best, which actually can tell us the patient is going to have an attack even before the symptoms have started. So it actually can predict the attack and prevent it by the timely intervention. And we can also check the effectiveness of our intervention by doing a post-bronchodilator test. So these are the zones actually of PEFR. We have a green zone when the PEFR is between the 80 to 100% of the personal best. Then yellow zone with the patient's PEFR is between 50 to 79% of the personal best. And the red zone, which is way less than 50%. So in the green zone, the patient does not have any symptoms. We can do all the normal activities. Whereas in the yellow zone, the patient may start feeling a bit of a coughing, fatigue, slight tightness, shortness, etc. So now, according to the asthma action treatment plan, we can actually take the reliever medications and start accordingly. But whereas if it is red, that is the patient is having so much cough, shortness of breath, not able to walk, talk, etc. And you get to a PEFR, it is less than 50%, it is high time, immediately call for medical help and start your cough of the reliever medications and go according to your asthma treatment. And then don't forget to seek the medical help once you are in the red zone immediately. Is there any possible risk or something while doing a PEFR? Generally, this PEFR is very, very safe. And very, very easy to do also. Only thing is we have to, make sure certain things are done properly. Like I told you before, that should be in the zero, and I have to tell the child very properly to give a proper exhalation so that there is no leak. When I found in my practice is like sometimes, kids, they tend not to purse their lips properly around their thing. That is one thing I felt. So you have to tell them properly, purse your. Another thing is like you're taking a deep inhalation and then putting it into the mouth and then giving it the exhalation, that they may actually take a little bit of a time. So what are the possible, sometimes the patients may get a dizzy or a disoriented feeling while taking a deep breath. And sometimes they may have coughing or wheezing as a result of a forced exhalation. These are only the possible, a little bit of risk in case of a PEFR. So that is all about our PEFR class. So I hope it is clear for you. So this is the PEFR thing. I repeat again. Take all the precautions, wash your hands, then explain the procedure, introduce yours. All this is you have to do. But once before you start the technique, make sure that you put this pointer onto the zero limit, the lowest value here. Here the lowest value in this PEFR is 60 actually. Some things are having until up to 0. Then they ask the patient to take a deep inspiration, put it into the patient's mouth, purse the, put it between the teeth and purse the lips around this mouthpiece, hold it and give a forceful exhalation and see whether it is moving. So always take a deep inspiration, okay, deep exhalation and a deep exhale is coming, okay. So this is what we should be doing and not just once, take it, do it 3 times. Again, then again, after again you can ask them to take it. It should be fast and exhalation, which we are doing onto the PEFR monitor. Record all the 3 values. Take the highest of the value. Like that you do in the morning, do in the evening. Get the variability by the formula highest minus lowest divided by average into 100. Like, then get the overall variability. Then find out whether the patient is having a excessive diurnal variability or not. This is a very useful monitor, which I actually, when there are also cases and all, we can actually ask the patient to purchase this, get the values recorded. So this will give a very good, patient also will feel very comfortable and they will have a pictorial representation of what exactly is, happening to their child, how is their airways. All this we can actually show them and tell them. So it's a very useful thing. And hope you can actually use it for your patients. I know many of you will be using it, but this is a very useful tool. And if you like this video, don't forget to like and comment. And thank you so much for your patient listening. Have a safe time. Thank you.